I think you've had a storied history in healthcare IT specifically, as an engineer, as a provider, and then leading a bunch of the national language on regulatory requirements. So it'd be great to get that background from you. And then maybe you can share how you got to your position in the government, but then also describe how that history has colored your vision for what the future should be. And then we can just take it from there and just have a conversation. And I can maybe take the lead of the conversation from our side, but it would be great for anyone else on the 1UP team to just jump in with whatever questions that you might have for Don yourself.
Okay, yeah. Well, let me go. Sometimes some of the early things are the most interesting. So on that note, I got started in this whole thing because, so we're talking, now late 70s. When I got on the clinical wards at Penn, it was pretty clear to me, just as a first-year med student, that medical care was irrational. Just the things I saw in my day-to-day, right? And when you're a first-year med student, it's a little bit of a big blur. You're a little bit in the fun house with lights and action, and you sort of you're overwhelmed by things, and of course dealing with actual human patients is quite sort of, I won't say tension generating, but sort of important and consuming. But putting all the sort of standard student learning aside, I realized this system is absolutely irrational in how it conducts its business and how it allocates the assets to conduct that business. And obviously that has a bit of an economic, operations research sort of bent to it. And then I try to figure out, well, do I just go and do something like business school, or do I actually try to do something about it? And somewhat immodestly, I decided, well, why don't I give it a whirl? It seemed like the thing was so inefficient. How could one not find something useful to do here? I had no idea how long it would take. So then I got interested in decision trees with, some folks. And so I was doing work on decision trees, somewhat exciting. When I became a resident, so intern resident, so an actual doctor with MD behind my name and patients I had to take care of, it dawned on me that the issue in healthcare was not want of decision support back then. There was no data on which to make a decision. This is a world when we were in paper charts. There was a little bit of electronic stuff on lab results. PACS imaging was a good 15 years away with the advent of cross-sectional CT scans. And then I decided I better learn computing. And so that was actually fairly daunting. So at this stage, I'm, finished residency. And, do you go back to school to do an undergraduate degree when you're a 30-year-old? I mean, many people have done it. But, not many people have done it who've just done a residency. Very few. And so I, sat on the fence a little bit, but ultimately bit the bullet. And as a resident, where all my fellow residents were applying to, become cardiologists or gastroenterologists or what have you, I decided to try to learn computer science. I was very fortunate through a series of things to be able to get simultaneously but unconnectedly into a just starting program at Stanford Medical Computer Science, where I was a grad student in Stanford's AI lab with Ted Shortliff, who invented rule-based expert systems. And at the same time, I happened to convince the people at Stanford Business School that I would do would be a MBA candidate. I may have neglected to tell one or the other that I was applying to another school. So when I got into both, which frankly I wasn't expecting, the business school turns out didn't care, and the computer science, Ted Shortliff, who's sort of med school joint, he was actually fine with that because it turned out that the regular med school faculty was giving him grief for admitting these, quote, losers who wanted to study computers, and diluting the name of the med school. And so Ted actually had a real benefit when a number of us turned out to have also gotten into other competitive programs at Stanford. That sort of shut up that whole conversation. So I didn't realize it, but this was sort of a proof for getting the program started. Any rate, a little bit of background, role-based expert system, master's project, the entire stack of computer science undergraduate, except for compilers, but, assembly language, operating systems, algorithms, data structures, databases, the whole shooting match. Was involved in building first Windows electronic medical records, starting with Windows 2.1, which was an exercise in memory management. We were the first people in the world to use Dragon, now Nuance, in a commercial product. That a whole interesting story. And, that almost succeeded, but, victory, defeat was snatched from the jaws of victory through a couple sort of management missteps that were visible ahead of time, sadly. And then joined Siemens, the former SMS, which at the time was the largest vendor of hospital IT systems, as chief medical officers. They were then purchased by Siemens. Couple major computer science missteps there, and but was heavily involved in rolling out on their legacy system, computerized physician order entry. We were, for a number of years, the second largest install after Epic. And, that was tens of thousands of docs at about 35 sites, roughly. I forget the exact number, but something in that 30 to 40 order. A lot of work there. Then a lot of work on imaging, lobbying in DC, and then some other career things, and ended up, my time at Siemens gave me some connections in the DC political world. So, noodling around there, I was able to get appointed as national coordinator. So that gives you the background. It's really I think, data first, analytic compute background with a massive personal investment in building skills in that space.
Yeah, no, and I think, Don, first of all, that's awesome. And you may have very quickly.
One last thing. Throughout that whole time, I was also practicing emergency department doc. So at a number of major teaching hospitals. So I've probably seen and taken care of on the order of about 10,000 patients as a frontline Rock'em Sock'em level 1 trauma center doc.
Yeah, and that's I mean, first of all, it's awesome to have someone like you that both understands the technology space and the healthcare space, then bringing that together to lead that for the country. And for those of you that didn't really catch what Don glossed over, is he literally led the ONC, the Office of the National Coordinator for Health IT, which is the group that is largely setting the requirements and the standards for electronic health record vendors and other healthcare IT infrastructure, along with things like the HITECH Act and meaningful use and all of this, regulation that we've seen over the last few years on the ONC side, which is somewhat of a counterpart to CMS, which has largely been doing it for the health plans and other parts of the industry. So I think that is, it's pretty great to have someone with your experience really have done that, because we appreciate, being technologists, not really having this data or these rules being created by people that don't understand the technical implications or the ramifications, as well as obviously the medical, implications, which are probably even more important. But that's great to have had you there. And I was actually on a call with Mickey and Steve and Stefan yesterday, where they were leading a bunch of, I guess, a panel discussion with a bunch of healthcare IT startups, where we were talking about, what are those things that are preventing innovation in this space, and what is it that the ONC can do to, further that innovation. What are your thoughts around that? Like, what is that role for, both the ONC, and what is it that maybe companies like ours can do to, unblock ourselves, or, unblock potential roadblocks that we find in these space?
Yeah. So I think the Cures Act provides an amazingly good substrate for, companies like 1upHealth, really, for folks who want to do new things. We can maybe later talk about TEFCA, which is a bit of a mess on a lot of levels. But the other two big provisions in the Cures Act, which are the prohibition against information blocking, and the requirement for application programming interfaces, quote, without special effort, unquote, really set up a very, very different dynamic on the access of innovators to data, right? That is both legal and technically feasible, right? Neither of which were really the case before when you dig down. And you're seeing this in the market, right? So when we started in 2017, Epic, to take, the largest vendor, was essentially an utterly closed system with no real, maybe they'd say, there's an API if somebody sort of, pretty pleases with, the powers that be, and, one of the lead customers. Now you have, App Orchard, marketing around Open Epic. And all of that, to be absolutely clear, came from seeing the rule about to be born. That was not a random event. That was entirely because of the Cures Act and the logical, outgrowths of, of that rule. So that's the surround. Then the specifics are, okay, an API without special effort. What does that actually mean, right? I mean, you guys are in the API building business, right? You sort of need a spec to build an API, right? It's not a trivial thing. You have to think a lot about, what's the data, what are the use cases, what's the security. What we came up with there, the work, the homework assignment, if you will, of rule writing, and just for folks who may not know, the way the things work in Washington, D.C. is Congress passes a law. So in this case, the 21st Century Cures Act. The IT, most of that was around FDA evidence. The IT section of that, which is roughly 40 pages in sort of legible print, as opposed to maybe 10 pages in Federal Register, triple column, 6-point font, is remarkably unspecific. So what happens is the laws say the secretary of whatever the relevant cabinet agency is shall, and then that means there's a rule. And so obviously for IT in healthcare, that was ONC that was, did the rule writing on that. So in doing that rule writing on APIs, we wanted a couple things. So first of all, we wanted to absolutely change what had been the current policy, that each vendor could do their own one-off API. That's just unacceptable from a public point of view. So truly standardized APIs. The second thing is you had to have something that lots of new developers could get into, which these days I think pretty straightforwardly are some version of RESTful. It doesn't actually have to be RESTful, but maybe more importantly is, JSON/FHIR for the data format, right? Because that's going to get the broader community of app developers, right? Probably the majority of folks on this phone call is going to empower them to be part of this. If we had made the API be HL7 version 2.53, essentially nobody, maybe one or two exceptions on this call would have really been empowered to do anything, or would have even considered joining 1UP, right? It would have been a non-starter. So that was, first order. Then there was, some real politicking on, and political calculation on, right? Because you have to, in the rule, if you want to be effective, have rules that people can actually do without, boiling over and complaining to their congressman, this is, horrible, right? You can't just, you can sit in Washington and say, well, yeah, wouldn't it be nice? That has often been done, maybe most notoriously with the Meaningful Use program that ONC did a couple years earlier, where they had these extraordinarily prescriptive rules on EHRs. Again, another long story for a different day. But it really behooves you, if you're smart, to do something that people can do so that the thing isn't overturned through a huge amount of heat and storm and noise with lobbying and upset, right? So you have to have something that can be done, and that has sort of, closure to it on some level so people can understand it and do it. So that consideration brought in a couple different things. So that brought in the very conscious decision to only require read APIs. A read API can be done through a database driver, no matter what the underlying, right? So if it's a MUMPS database, as with another number of the vendors, or SQL database, so you can have your, ODBC type of driver. That's a computable thing to do. Write APIs are much more complex because they implicitly and explicitly make assumptions about the internal architecture of how function calls are laid out and thing, what the performance is of the innards. You can have denial of service things. It's just a vastly more complicated thing. And I easily foresaw that the lobbying that would, be on that potential denial of service attack would shoot down the entire rule and access to APIs. So we didn't go there. Over time, clinical decision support hooks, some of the prior auth stuff, some of the Da Vinci things, these things can be built out, but it's a different process. So that's one part of having an accessible API for a startup. The other one is having some closure in the data, and the core data for interoperability, now marginally renamed US Core Data for Interoperability, I think was a good set there. The law says all data, as you guys know better than anybody, all data doesn't have data standards or architecture. And so the best you can really do for data dumps is do just, at least that that we could tell, that I could tell, which just require a vocabulary tag on it. My guess is that rest of data will be an NLP project. But hopefully that gives you a sense of what we put into the rule, along with a whole stack of considerations on pricing and information blocking, right? Because it has to work technically, and then it has to work financially. And so I could bore you for hours with all the stuff we did on pricing considerations on these APIs. That's very complicated because you have essentially a number of parties with economic interests that conflict, right? So you have the EHR vendors, you have the providers who are captive to an EHR vendor, you have the patients. But those were, that combination of technical and cash flows were the things that we did to let an app economy flourish.
Yeah, no, that's awesome. I think that definitely got the ball rolling in the right direction. One thing that I also posed to Mickey and team yesterday that I'll ask you too, which is not an easy question to answer, but it's fundamentally, I think we need to get the other parties in the industry to want to make their data more available rather than need to do it. And under the regulatory environment, they need to do it. They don't actually want to. They're kind of dragging their feet a bit still. And it it makes sense given the incentives that are in front of them today, and the business and revenue growth and all this other stuff, right? But what do you think is going to be required to really transform the industry so that the EHR vendors, the payers, the providers actually want to make this data available, so that we don't need meaningful use 3, and then we don't need another layer of regulations on that to actually publish the APIs, and then another layer of regulations to provide timely access to the APIs and so forth?
Well, that's the $3 trillion question, since that's how much we spend on healthcare in the US, roughly a year all in. So I think everybody has to understand the economics of healthcare are sort of very, very complex and odd, because, and we talked about it at lunch, I think briefly, some of the regulatory history going back to World War II, literally, when healthcare was made a pre-tax benefit, which sort of distorted the entire set of incentives forevermore. What you have to understand is healthcare is not a free market thing for the most part. There are things at the edge, LASIK, plastic surgery, but even those aren't really free market because of all the guilds and regulations. And so what you have is this extraordinary complex sea of government incentives. And so as somebody in the space, you have to understand, how does this sea of incentives play out for, me, wherever you are, 1upHealth, a doctor, a nurse, a hospital, a payer, right? So you have to have some, ideally, an organic sense. Most people really don't quite understand the complexity of the environment or how the incentives fully play out, but the smarter you can get about an understanding of this broad sea of incentives, the better off you are, the more nimble you can be. So for you, the incentives, and for, I think the relevant ones are, the dominant incentive, as you point out, has been to have an inward-facing delivery system to capture high-margin procedures that have administratively high prices set by Medicare and then the payers, right? So to capture, heart surgery, spine surgery, cross-sectional imaging, right? That's, if you're a CEO, that's the world you see, right? So a number of you maybe are in Boston. There's a health system that starts with a P in Boston, right? That's a perfect example of trying to funnel all high margin business and capture it, right, into the meccas. And you can go wherever else you want to, Maine Medical. You can go out to Pittsburgh, UPMC. You can go out to, Chicagoland, Aurora Advocate, Barnes Jewish, Orlando, Florida Health, or down Orlando, all the way out to Sutter, and you see the same playbook, which has become an inward-facing delivery system. That's in essence what made Epic. That doesn't really share data except maybe at the edges, right? So what that means is you have to be mindful and frankly lobbying to have in DC to sort of call a spade, and then think at the margin, how do you incent these APIs? That's in essence, right? So the Cures Act can be seen as a mid-course correction, right? Congress noted, hey, this stuff we're doing has led to no sharing of data. Let's change the trim tabs or stabilizers. I don't know anything about flying, but I think those are parts on the wing that direct the airplane. Maybe somebody knows, right? So that we'll make a mid-course adjustment in flight that we sort of get the bird to something better. So you have to think wherever you are of this sort of environment you've been sat in, and then you have to sort of either work the environment, right, the design of the environment, right, which is hanging out in DC, articles, publication, lobbying, or work the narrative for the different folks out in the field. So an example of working the narrative out in the field that we talked about very briefly at HIMSS is payers have a bit of an existential issue of what the hell they're doing, right? Because payers in America, though they're called insurers, they really don't economically act as insurers do, right? True insurers act to take rare, unpredictable, at least unpredictable at a class level of insured risk and spread that over, right? It seems like that's what payers do, but what payers actually do is transaction handling on claims, right? It's a different business. If you think of them as insurers, you're sort of half missing the boat. So then the question becomes, which you guys are working hard to, how do you convince them that they can have a richer, better, higher margin or protect the margin role through these modern technologies? So to sum it up, you have a very, very funny non-market environment that that everybody in American healthcare sits in. You have to understand all of the more bits and pieces of that you can understand, the better off you're going to be. And then you have to decide, are you going to be more effective in lobbying in DC to change the environment, which is often quite doable for a variety of reasons, or will you be more effective at the periphery, changing of the narrative around the environment? 1UP probably needs to do both.
Yeah, I totally agree. And I think, the point that you mentioned about the incentives for the payers and what is their role, are they the party that really has the member patient's best interest, and is the patient, holding their allegiance to the payer, or are they holding it to their employer, which might switch plans over time, or the individual might move and therefore get a new payer, or are they, holding it to their provider, where they have this PCP and they want to stick with that doctor, forever, whatever. I feel like depending on who you are, your allegiance may vary. But where do you see it kind of playing out in the long term? Because there aren't these sorts of long-term relationships in healthcare, at least for the broad market, as there are for other industries, like maybe a bank, or maybe your, phone, software, for example.
Yeah, I think, this is now predicting the future, right? Which was it Yogi Berra or somebody says very hard to predict or something, right? So this is entirely speculative and these trajectories can be totally changed by individual political events and narratives, right? So American politics is a big randomizing machine, right? It's like a random number generator on policy. And so modulo that, if you sort of look at it, I think you're going to see, right. Ricky, yes, both of you, you got the quote. All right. Great search skills. Very good. Multitasking search skills. I think there's a couple underlying trends to think of. So first of all, more and more of the costs in the commercial sector are being dumped back on employees, just because of the volume of the costs and what employers can do. So there will be I think there'll be more sensitivity. We'll see how the price transparency rules, how that sort of evolves. But I think over time, there will be sort of pricing transparency in some level. God knows it's taken a long time. I think you're going to see that. I think you're going to see more payer, payers to date have offered a relatively undifferentiated product when you get right down to it. I mean, it depends on the class of insurance, right? I'm talking about but within commercial, within Medicare Advantage, within whatever, the products have been, relatively undifferentiated. I know when I was at Siemens and, had discussions with our HR people about whether, we should, do some of these sort of payer side interventions. I mean, it was all about, they would switch payer for 1 penny per member per month, I swear. I mean, just bizarre. So the payers, I think, to your point, Ricky, have made a very poor story, both on their side and on a policy side, in having incentives to longer term contracts, which would be preventative medicine and better healthcare. I think you alluded to the fact that in other insurance, your driver's insurance, there are good driver discounts. If you're doing commercial insurance, like of a building, or, errors and omissions for a board of directors, all of those things have contractual provisions that go over time to have longer term incentives for good behavior, if you will. We don't have those incentives, and the people who do the longest term insurance, which is Medicare, the VA, right? The folks who are in essence in terminal insurance programs, to be brutally blunt, for various reasons, they haven't fully felt empowered to do that. And that's, again, government policy and narrative and how they formulate things. I believe the whole bulk FHIR world will actually start moving things. So to summarize the question, you're going to have more consumer demand with price transparency. I think there are going to be tools from wherever on delivery system performance that I think will put a lot of pressure on the oligopoly delivery models, because they will be found, I believe, to not have performed for the price margin they capture, including maybe, ones that start with a P in Boston. And by way of disclaimer, I worked at Beth Israel for many years, so I was on the other side of the fence or other side of the avenue. And I think the whole payer world has an opportunity to get smarter that will drive a dynamic. Right now, that requires a political narrative on what to do. It may require additional policies, but that narrative has to be built up. But I think it's there for the taking.
Yeah, and with these providers that you kind of mentioned that have these geographical strongholds, right, through acquisitions or mergers or whatever you want to call it, they are creating a place where it is hard to shop around, even if you have price transparency and you have data sharing. You don't necessarily have the market of competition that you would want or need to actually drive down prices. And I think you mentioned Sutter Health. There's kind of a big thing out about Sutter, about that previously. What do you think is going to actually change that? Like, do you think there is something that can be done, or free market kind of is always going to incentivize aggregation here?
Well, it's not the free market. It's the response to federal price setting that has incented the aggregation, right? For the most part, right? Because this aggregation is not necessarily around things that are true volume scale effects, right? This is not like, it seems like it is, but the underlying cause is not, for example, why railroads want to merge type of thing. And that's a very subtle argument about information flows. I think that, some of this can honestly be done in regulation. CMS unilaterally, if a CMS administrator wanted to change pricing levels on this, they have absolute power to do that, right? So, for example, if you have a certain oligopoly market share, you get knocked off a certain percentage on your fee schedule, right? They absolutely have the right to do that. I think, and Sutter, you take Sutter, I was told by folks at Google, a number of years ago, that Sutter raised their costs by 35% for healthcare. Google being, at the time, sort of a Bay Area operation for the most part. There was a study, I think about 2 or 3 years ago, that showed that inpatient surgery in Northern California cost almost twice as much as Southern California, where somebody did a pretty rigorous thing.
Yep.
So what I think is going to happen is you're going to see that the beauty of the bulk data potentially is you're going to be able to have a much richer, because right now, if you're an employer, you have no argument to make to your employees why somebody's not in network, right? Well, why don't we allow MGH, right? So you have no real data-driven argument to make. When with bulk, and maybe the tools that you guys can build, right, you're going to have potentially arguments to make, or the payers as our buyers will have arguments to make in negotiation on, you're doing X, we're not going to pay you 2. Let's say you're doing X% better. If you're doing X% better at all, we're not going to pay you 3X for the X% you're doing better. We'll pay you X for the X% you're doing better. I believe that any modern machine learning algorithm will actually start pumping out some of these correlations between performance and payment, because the payers know what they've paid for these services. So that's a long answer, because this is a very, intertwined world. But I think those dynamics can be and will be, potentially quite effective. That's one of the opportunities for 1UP. The other thing to, of course, be aware of is just, there's a twist of the political dial and some single payer thing is mandated, or some way more rigorous price mechanism. And, this kind of stuff has sort of happened in various versions in the past, right? DRGs, for example, were quite transformative back in the day, right? So before DRGs, which were fixed prices for hospital stays, we would, as residents, go and take little stickums off every IV bag, every IV catheter, everything we did, and put them on like a 5x8 file card at the patient's bed. And the hospital would bill out to payers every single one of those line items. And hospital bills, the aspirin for $10. Every one of those things. I see somebody who was part of that era, right? Every one of those things would get billed out. And finally, Congress said, screw this. We're going to give you a fixed price. The year for that was 1982, I believe. Screw that. And that changed a lot of the incentives, right? Which at that point had been, aligned to that sort of piecework type of approach. So as you run companies, and you just have to be aware there are going to be disruptions here, and then you have to sort of recalibrate what the disruption in policy is going to mean and what the opportunity that follows is.
Yeah, totally. So the others on the team, you guys should feel free to interject with other questions. But I did want to ask one more,
Sure.
and to stick with never making predictions, especially of the future, as Yogi Berra would say. I'll ask you, what do you want the future of healthcare IT to look like? Maybe not what do you think it will look like, but what do you want it to look like?
If I could wave a wand, and of course, the reality is when a wand is waved by government, bad things happen. Just sort of in the history of economics, free markets dominate in terms of creating better lives for citizens. But there are a lot of people who don't see that, and that's been this struggle going back for literally hundreds and hundreds, if not thousands of years. I think a world where consumers control their data totally, so that EMR sits first with the patient, and then providers access it. And that happens, I think, in a couple places like Thailand, I'm told. I don't have primary data on that. But, I think in an ideal world, consumers own their data and give rights to other people to access it, is, I think, one thing that will be transformative over time. This is, all the stuff that we did is sort of, I think, a step there. The other, maybe more immediate thing is, we talked about this briefly at lunch, but today in the US, healthcare, especially hospital type care, is paid for under 4 mechanisms. One is just what's the lowest price, right? So you're a payer, let's say a Medicare Advantage narrow network. I'm just going to contract with the people who give me the, lowest cash on the barrel price. The second way is, which is maybe the dominant way, is I'm going to bulk up a delivery system so large, we talked about Sutter or UPMC that pioneered this, that the payer has to have me in network, essentially no matter what price I set, right? This fits under, I don't know, it's Cole Porter, Ella Fitzgerald, but you guys can look it up. A song somewhere before all of our times called Nice Work If You Can Get It. Right, I mean, that's great. If you can have somebody, if you can force somebody to pay your charges no matter how high they are, what could be better if you're that somebody? Not so good if you're the person paying. The third way is, paying on the base of today's sort of very flaky quality measures, which are essentially fictional, but that's sort of what CMS in part does for adjustment. That's what a lot of private payers do. It's like antimatter to data science quality measures. They're little regulatory nuggets. If you based a conclusion in an undergraduate data science course on the analogy of quality measures, you'd fail. So, but in government, it's called pay for value.
Take the undergrad data science course.
What?
They didn't take the undergrad data science course.
Okay, they didn't, I assure you. And the fourth way is, you can sort of do eminence-based medicine, right? Man's Greatest Hospital type of thing, or Cleveland Clinic or Mayo or whatever. What you've noticed in those 4 ways of buying healthcare, none of those 4 have what consumers do, which is, if you want to look at it in microeconomic terms, when a market clearing price where the marginal utility to me as a consumer is equal to the marginal cost of a producer willing to provide me the service. In other words, I'm getting a good deal. I'm getting value for the buck, right? None of those payment things have that, because we sort of know what the buck is. We don't know what the value is. And I am very optimistic, and this is, I think, the excitement for 1UP, is that bulk FHIR and this whole broader world and modern machine learning is for the first time going to give us, with lots of work on explanation, but is going to give us a true, not a fake way of calculating value. When that happens, and when that dynamic is recognized, this entire world will change. It'll just change. That's my hope and vision.
Yeah, no, that's awesome. And I think we are really excited about that because we do have our hands on a ton of great data to help our health plans with,
Yep.
where we can actually look at the cost, figure out what happened with respect to quality. Did this patient get readmitted? Did they continue down the same wrong path, and all that stuff?
Well, the beauty of the machine learning is you can even do subtler things, right? I mean, the reason we've used things like readmission is because those coarse measures were all we had. With machine learning and big data, you're going to be able to look at much subtler signals and gain insights, I believe. I'm an optimist about this. Obviously, I've been doing this for a long time, driven by a vision of the future. But I think for the first time in my entire career, right, I've been through all kinds of approaches, decision trees, expert systems, early neural nets, clinical decision support. I think this is the first one where my gut tells me this is going to stick and work.
Yeah, that's great. And Donna, you had a question. Do you want to go ahead and shoot that out quick?
Yeah. So,
Hi.
hello, Dr. Rucker. I'm the nurse on the team, and
Sure.
so many points you've made have just
Yeah,
made
feel
me
free to call me Don, by the way.
Hi, Don. I'm Donna.
Excellent.
So my question is around, do you foresee more stricter guidelines on the ethical use of this data? Right now, there's a lot of loopholes. We saw it in just the last year with Ascension and Google, the data science they did with Project Nightingale. And then also we've introduced now that app developers don't have to be ONC certified. So, we have these guidelines in place for the certified vendors, but what about, the non-certified? So, you mentioned things about historically, we threw out World War II and stuff. We're talking about moving towards a national exchange of basically the socioeconomic profile of every person in our country. Is there going to be more strict guidelines on the actual use of patient data for deeper analytics?
Yes. And, some of this can be quite nasty, right? Because somebody who doesn't want to share data will, as they already have, make arguments. They're, quote, protecting the patient by, making, for example, somebody get, comply with HIPAA, right?
Right.
I mean, right. So that sounds like, oh, that sounds good. Sounds like, get me one of those, right? Let's unpack what that means. That means the covered entity that is overcharging me is now going to control whether I have access to my own data. Are they going to let a competitor have access to the data? Imagine if, pick any service and you were told that vendor is going to control your life so you can't shop, right? So, and believe me, there's already legislative language that has been proposed that says exactly that, by a series of scumbags, to use a technical term. But, with a straight face. And so, part of the deal here is to be monitoring that, understand how you lobby against that, have pathways with the relevant staffers so that you can get a heads up, see language on those things. So that's the street fighting in DC, right? That's the inside the beltway stuff. And very hard for, a small company like you guys, but, you have to ally with people and with politicians and some of these things can happen literally overnight, right? because the people who are anti-consumer, you know, I mean, there's thousands of healthcare lobbyists in DC. They'll put a provision in that they sneak in literally the night before some must-pass spending bill, and the White House has already said, oh yeah, we're going to sign this, right? Maybe the infrastructure bill or something. And then you have something. So this, like all attacks, require constant vigilance. That's on the sort of you know, snarky low down in the weeds level. The broader there are two broader philosophic points on privacy. First of all, most health data, lowercase health, is actually totally outside of HIPAA and medical records. It's the accelerometer on your phone, your search history, your credit card history. If I know you spend all your time at the liquor store or the McDonald's or the, you know, lazy boy recliner in your, you know, in front of your TV, as opposed to the climbing gym, you know, running 4.5-minute miles, you know, hiking as my brother and his wife are, you know, on a 5-day hike in Sequoia, right? I already have a huge economic differentiator in writing insurance policies or hiring or what have you. So most data, this is the point I try to make, has nothing to do with HIPAA. So you can batten down and make healthcare as anti-competitive as you want with, quote, HIPAA protections, unquote, which are, of course, very much anti-consumer in pretty much all cases. And then the other issue is, as a country and as a planet, we haven't figured out privacy. My belief is that what we need to do, and this again might be a great opportunity for 1UP, is figure out somewhere on the trifecta of authentication, authorization, and consent, right? So it goes way beyond a patient identifier, but it's who are you, and what do you allow of your data to be seen by whom else, and what of whom else's data, your minor child, you know, your 15-year-old's OB type of history, you know, your spouse, your ex-spouse, your parents, whatever. What privileges do you have for others? And so we have to solve that trifecta of authentication, authorization, consent, and certainly be aware of it. I think that has to be a computable bundle, right? You know, a FHIR resource, if you will, to because I think that's, to my mind, the most tractable way of giving people control, having accountability, and addressing privacy. You know, clearly things like the GDPR, where everybody clicks through some banner on a web page, you know, do you accept cookies? I mean, that's faux consent.
Yeah, no, that's really fascinating to hear from you, and I totally agree. Maybe in the last 2 minutes, we'll do one more question. You know, with these new price transparency rules coming and more people aware of the balanced billing, this is from Alex on our team, do you think payers are going to need to incentivize their members to follow through with their care plans? How is that going to change the way that, you know, the doctor network payer relationship works?
I think that's largely to be determined. The balanced billing stuff, as you know, right? So, you know, typically for folks who don't know, it's you go to an ER, you think you might be a network, you're not, and, you know, either the ER or the anesthesiologist give you some cosmically high, non-negotiated bill. You know, it's often called surprise billing. Balanced billing is actually a little bit of a subtle different thing, but they're in the same camp. Those are, you know, I think there's still going to be rulemaking on that. It really gets to some of the economic tug and war. Again, that's part of the opportunity for 1UP, is to provide ammo, data ammo in these policy arguments, right? You probably don't think of yourself as a weapons supplier. You know, that probably not in your business plan to be a weapons supplier. but you very well, could be.
Yeah.
And,
Well,
again, like most weapon suppliers, it's probably going to be sort of subtle.
yeah. We'll add that.
Unless you're advertising at the Pentagon stop of the DC Metro, where for those of you who don't travel on the subway here, at the Pentagon stop and nearby stops, the subway ads are not just wear your mask and the lottery and some other thing, but fighter jets flying through the sky.
We'll get there one day.
Yeah.
Yeah. Thank you very much, Don. This was great. And Judy, I don't know if you have any other closing remarks to make, but
well, thanks everyone. Yeah.
Hey, thank you so much. Enjoyed the conversation, and you've really been a stalwart in promoting interoperability. And thank you for taking the time today.
My pleasure.
Yeah, we
Thanks,
appreciate
everyone. Take care.
Thanks, Don.
Thanks for all the thank yous. Appreciate it.
See y'all.
Bye-bye.
Bye.
We'll follow up offline. So I'm gonna.
Yeah, definitely. Thanks, Don. See ya.
Bye.